Welcome back to the deep dive. Today we're doing something a little different. We're performing, let's call it highly focused surgery on some really dense medical sources.
That's a good way to put it. We're extracting the absolute core knowledge you need from material that's, well, it's pretty specialized.
It is. Our mission is laser focused on male urethral and penile disorders. We're diving deep into some surgical guides and lecture notes.
Right, and this isn't just theory. The source material is from Dr. Senthil Kumaran, and it's a clinical roadmap. It's exactly the kind of high-yield, prioritized information that's, absolutely non-negotiable for anyone tackling major medical entrances.
Exactly. Things like the NEAT PG, INI-CET, or MCH urology. So think of this deep dive as your shortcut to getting functionally well-informed on everything from trauma and congenital anomalies to strictures and, yes, malignancy.
And our goal isn't just to list facts. It's to get to the why, the management principles, the crucial anatomical details that really drive surgical decision-making.
Before we jump in, though, we have to talk about the author of these notes. Understanding Dr. Senthil Kumaran is, well, it's vital context. It explains why this material is so reliable.
It really does. He's an associate professor at AIIMS Nagpur, so he's operating and teaching at one of India's absolute premier institutions. This isn't just some textbook summary.
And his pedigree, his training, it just guarantees that rigor. He did his MBBS at JPMER, Puducherry, and his MS at PGIMER, Chandigarh.
Both top-tier institutes. I mean, that's a foundation that establishes a standard reflecting global best practice.
And it shows in the notes. There's this clarity, this prioritization. You can tell it comes from his own experience, but also his mentorship under Mr. Nilesh Lathaji, sir.
Yeah, that vision he mentions using innovative memory techniques, animation-based learning, it's all about effective knowledge transfer.
And that's precisely why these notes are perfect for what we do here. They distill years of complex surgical experience into really memorable clinical anchors. We know we're working with material from a master surgeon and teacher.
Absolutely. So with that foundation set, let's jump straight into the geography, because in urology, anatomy is, well, it's everything.
It really is destiny. You can't understand where and why injuries happen until you understand the segments of the male urethra.
Exactly. Let's get into it.
So we're looking at a structure that's about, 18 to 20 centimeters long in total?
Roughly, yes. And Dr. Kumaran breaks it down into 4 very distinct anatomical segments.
And the differences between them, width, mobility, length, they're the key, right? They predict the pathology, the surgical approach, everything.
Everything. The structure is not uniform at all, and that heterogeneity explains why one type of trauma is a minor tear and another is just catastrophic.
Okay, so let's start at the beginning, right near the bladder neck, the prostatic urethra. This one holds the distinction of being the widest and also the most dilatable of the 4.
Which is a bit counterintuitive. You hear prostate and you immediately think of obstruction, BPH, in older men. But the prostatic urethra itself, its lining, is actually designed to stretch. It's built to accommodate things like instruments during a procedure.
Like a TURP, a transurethral resection of the prostate.
Exactly. That inherent distensibility is why that procedure is even possible. It also means if a small kidney stone makes it past the bladder neck, it's probably going to clear this segment pretty easily.
Okay, moving on from the widest part, we immediately hit a crucial bottleneck.
Yeah.
The membranous urethra.
And this is its polar opposite. It's notorious for being the narrowest internal part.
And, critically, the least dilatable.
Yes. And that combination of features is deadly when major trauma happens. The membranous urethra passes through the deep perineal pouch, and it's fixed really firmly by ligaments.
The puboprostatic ligaments.
Right. So it's narrow, it's rigid, and it's fixed in place. That means when there's a massive external force, like in a car crash that shatters the pelvis, it doesn't stretch. It snaps.
It just shears right off.
Exactly. That rigidity is why it's the primary victim in those severe pelvic fractures.
Okay, so third in line is the bulbar segment. This one is known for being the longest of the 4.
It is. And its length, combined with its location right under the pubic arch, just past that rigid membranous part, makes it uniquely vulnerable to a very specific type of injury.
A crushing force.
A crushing force. We'll get into the specifics in a moment, but its anatomy really sets it up for that.
And finally, we have the penile or spongy urethra. This is the segment that runs through the corpus spongiosum.
Making it the most superficial part of the tract.
Which means it's more vulnerable to direct impact or, say, instrumentation injuries?
It is, though they tend to be less catastrophic than what happens to the fixed posterior segments.
So if we pull all that together, widest is prostatic, Narrowest internal is membranous, longest is bulbar, most superficial is penile. We can distill this down to the key clinical takeaways that Dr. Kumaran really emphasizes.
Yes, there are three absolutely crucial points to remember.
First, the single most constricted point of that entire 20-centimeter path,
That would be the external urethral meatus, the very tip.
the exit point.
Hmm.
But while it's the narrowest overall, it's also, I suppose, the most accessible for treatment.
That's a great point. It is. A lot of simple strictures happen there, and they're relatively easy to manage compared to deeper ones.
Okay, point two. This one reinforces what we just discussed.
The narrowest internal part is, without a doubt, the membranous urethra.
And that distinction is key for exams, right? The meatus is the narrowest overall, but the membranous part is the narrowest inside the body.
You have to know that distinction. It's a classic high-yield fact.
And the third point, which is our perfect segue into trauma.
It's the most common site where injury actually occurs, and that's the bulbar urethra.
Okay, wait, that's interesting. The membranous is the narrowest internally, but the bulbar is the one that gets injured most often.
Exactly. And what does that tell you? It tells you that the mechanism of injury is usually not some internal shearing force. It's an external blunt force focused right on the perineum.
The anatomy predicts the pathology. So let's connect that anatomy directly to acute trauma. This is where the location anterior versus posterior becomes critical. It dictates everything: the cause, the severity, even the associated systemic damage.
Let's start with the more common one then, anterior urethral injury. This almost always involves the bulbar urethra, our longest segment and the most common site of injury.
And the cause here is very specific. It's that classic straddle injury, right? Or trauma from medical instrumentation.
Right. Let's focus on the straddle injury because it's so illustrative.
Paint the picture for us. What exactly is happening?
It's usually a fall onto something narrow and hard. Think of a metal beam, a bicycle crossbar, a fence railing. The person falls, and their perineum takes the full impact.
And the bulbar urethra is right there.
It's right there, and it gets violently crushed and compressed against the immovable, rigid, bony structure just above it, the pubic arch.
So it's sandwiched.
It's sandwiched and sheared. That force causes a tear or a complete rupture, but the injury is typically localized just to the perineum.
Okay, now contrast that sharply with a posterior urethral injury. This involves the membranous urethra, the narrowest, most fixed part.
And these injuries are almost always linked to major, often life-threatening trauma, specifically a severe pelvic fracture.
The mechanism here is totally different.
It's catastrophic. When the pelvic ring is violently shattered in, say, a high-speed collision, the bone fragments are massively displaced. And because the membranous urethra is tethered by those ligaments to the pelvis and prostate,
It gets torn apart.
it gets sheared completely. The prostate, which normally anchors everything, is often displaced upward, which leads us directly to one of the critical signs of this injury.
Okay, so given these severe mechanisms, what are the absolute must-see clinical features? The red flags that should make any clinician immediately suspect a urethral injury.
There are four that you just cannot miss. First and most immediate, blood observed at the meatus, even a single drop.
Urethral bleeding confirms a breach somewhere in the tract.
Right. If you see it, you stop. You assume the urethra is damaged until you can prove it's not.
Second is the functional consequence. The patient tells you they can't pee.
Yes, the inability to pass urine. They're in acute retention and they're in a lot of pain.
Third, this is the classic, you said, the pathognomonic sign for that posterior injury with a pelvic fracture.
The high-riding prostate. If the membranous urethra is completely severed, the prostate is detached from its anchors below. When you do a digital rectal exam, the prostate feels unusually high up.
Or you might not even feel it at all.
Exactly. It can be so displaced superiorly that it's just not palpable in its normal position.
And fourth, the definitive visual sign, the one that confirms severe blood leakage.
The perineal hematoma presenting in that very distinctive butterfly pattern.
Okay, that butterfly pattern is such a classic image. Explain the anatomy behind it. Why that shape?
It's a perfect example of anatomical compartments. When the urethra ruptures, blood leaks out. If Buck's fascia, that's the deep layer of tissue surrounding the penis and its structures, is intact, the blood gets trapped.
Trapped where?
In the superficial perineal pouch. This pouch is bounded on the sides by the ischiopubic rami and at the back by the perineal membrane. So the blood fills this defined space.
And it can only spread outwards.
It spreads outwards in a fan shape around the scrotum and perineum, creating that unmistakable bilateral butterfly wing appearance. seeing that hematoma is definitive proof of extravasation.
Okay, so we've got the signs. We suspect the diagnosis. The patient is terrified, in pain, can't void. Now we get to what Dr. Kumaran calls the single most important rule in management. It's in bold in his notes. Never insert a Foley catheter if urethral injury is suspected.
It cannot be emphasized enough.
Let me push back on that, though, for the sake of argument. The patient is in agony from retention. Isn't immediate relief the priority? Why would you delay simple drainage if you're not 100% sure yet?
It's the ultimate clinical test of nerves, but the rule is absolute for one reason. The risk of permanent catastrophic damage outweighs the need for temporary relief through that route.
Explain that risk. What's the worst-case scenario?
Let's say the tear is only partial. The patient might even be able to pass some urine later. If you blindly force a stiff catheter past that injury site, you are almost guaranteed to do one of two things.
Okay.
One, you convert that partial tear into a complete transection. You literally sever the urethra completely. Or two, you create a new, jagged, false passage through the soft tissue.
And that conversion from partial to complete, that's a huge deal surgically, isn't it?
It's the difference between a potentially simple single-stage repair with excellent outcomes and a multi-stage, highly complex reconstruction with a much higher risk of lifelong strictures, incontinence, and impotence.
So that 1 minute of action trying to place a Foley could ruin decades of a person's quality of life.
Precisely. If you even suspect it, you treat it as real. So our diagnostic step cannot involve blind instrumentation. The investigation of choice is the retrograde urethrogram, or RUG.
Walk us through the RUG. What does it look like? What are you looking for?
It's an imaging study. We gently insert a small catheter just into the meatus, the very tip, and inject a radiopaque contrast dye backwards, or retrograde, into the urethra.
And you take x-rays as you do it.
Yes. If there's a rupture, we see the dye leaking out of the urethra into the surrounding tissues. We see the extravasation. This tells us exactly where the tear is, and crucially, if it's a small leak, meaning a partial tear, or if there's no dye getting to the bladder at all, meaning a complete severance.
Okay, so since the Foley is out, the immediate treatment pathway has to be all about safe drainage.
The first priority is to relieve the bladder pressure without touching the injury site at all. That means suprapubic catheterization and SPC.
You're going in from above.
Right. A small incision is made just above the pubic bone, and a drainage tube is placed directly into the bladder. This immediately relieves the retention, stabilizes the patient, and, importantly, it allows the traumatized urethra to rest and begin healing without being constantly irritated by urine flow.
What about the definitive repair? You can't just leave a severed urethra indefinitely.
No. The strategy is almost universally delayed urethroplasty.
Why delayed? Why wait?
Because you have to. The initial trauma causes a massive amount of local swelling, inflammation, and hematoma. If you try to do an immediate repair in that messy, unstable environment, your sutures won't hold. The repair will break down and you'll get massive, debilitating scar formation. A terrible stricture.
So you wait weeks, maybe even months.
You wait for the acute inflammation to go down, for the hematoma to resolve, and for the initial scar tissue to mature a bit. This maximizes the health and blood supply of the tissue you're actually going to stitch back together.
And for those severe posterior injuries, the repair is more complex.
Yes. For those, the specialized requirement is often an end-to-end anastomosis. You have to cut out the scarred segment that has formed between the two retracted ends of the urethra and then meticulously stitch the healthy ends back together. It's technically very demanding, given how deep and fixed that area is.
The key is patience then. Stabilize, drain, and reconstruct much later.
That's the mantra.
Okay, let's shift focus. We're moving from external trauma to internal sudden structural failures. The real acute penile emergencies that require action within hours to save function. These are dramatic.
They are. And we start with the classic non-bone break, the penile fracture.
The name is a bit misleading. There are no bones.
No bones, but the event is just as terrifying. It's defined as a tear of the tunica albuginea.
Which is?
It's the thick, white, fibrous sheath, a really tough casing that holds the pressurized blood inside the corpus cavernosum during an erection. When that casing tears under pressure, the whole system fails instantly.
And the clinical presentation is immediate. It's traumatic. It's basically its own diagnostic clue.
Almost universally, patients report hearing a sudden audible crack sound. That's the sound of the tunica snapping.
And that's followed immediately by acute pain and critically rapid detumescence.
The immediate loss of erection, the pressure is gone.
But it's the physical sign that really seals it, the eggplant deformity.
Yes. The pressurized blood that was in the corpora leaks out of that tear in the tunica. It floods the subcutaneous tissues, but it's constrained by that dense buccal fascia we mentioned earlier.
So it swells up fast.
It swells rapidly, it often becomes curved or bent, and it takes on this characteristic deep purple or dark blue color from the bruising, the shape, the color. It looks like an eggplant.
It's a powerful memory hook, but it also signals absolute urgency.
Yeah.
What is the mandatory management here?
Immediate surgical repair. There is no room for observation. You cannot wait.
What's the goal of the surgery?
The goal is to get in there quickly, open up the hematoma, drain all that clotted blood, find the tear in the tunica albuginea, and suture it closed.
And if you delay, what happens if you wait a day or two?
Delaying surgery risks extensive fibrosis and scarring at that tear site. If that scar tissue forms, it creates a hard, fibrotic plaque.
And that leads to a permanent problem.
Yes. It leads to severe curvature, what's known as acquired Peyronie's disease, which can make future intercourse painful or even impossible. On top of that, the structural damage compromises the whole veno-occlusive mechanism, leading to chronic erectile dysfunction.
So swift action is the only way to preserve function.
The only way.
Okay, our second major emergency. This one operates on a time-sensitive ischemic clock. Priapism.
Priapism is defined as a persistent, painful erection lasting more than 4 hours, and it's completely unrelated to any sexual stimulation. The key word there is painful. Pain is the body signal that the tissue is suffocating.
And we have to distinguish between the two types. First, the most common and dangerous one, low flow or ischemic priapism.
This is the true critical emergency. Low flow means the drainage mechanism is blocked, the venous outflow channels are completely occluded, so blood gets in, but it can't get out.
And that trapped blood becomes stagnant.
It becomes stagnant, it gets deoxygenated, and it becomes extremely acidic. Every minute past that 4-hour mark is critical. You are literally watching the oxygen levels in that tissue plummet.
What's the point of no return?
After about 24 hours, the chances of restoring any meaningful erectile function drop almost to zero. You're looking at widespread cellular death, necrosis.
Okay, then there's the much rarer type, high flow or non-ischemic priapism.
This is a totally different beast. It's usually caused by trauma that created a tear between an artery and the corpus cavernosum, an arteriovenous fistula.
So fresh, oxygenated blood is constantly rushing in.
Exactly. Arterial blood rushes in, which keeps the tissue oxygenated, so it's usually less painful, and it isn't an immediate ischemic threat like the low-slow type. It still needs management, but the clock isn't ticking quite so loudly.
What are the key systemic causes that lead to that agonizing low-flow state?
Sickle cell disease is a huge one. The rigid, sickled red blood cells clump together and physically block the small outflow venules.
And certain drugs.
Certain drugs are notorious for it. The antidepressant trazodone is a classic example. Some antipsychotics, and often, ironically, medications used to treat erectile dysfunction.
The PDE inhibitors, like Viagra.
Yes, especially when they're misused or combined with other agents. Also, trauma and neurological issues like spinal cord injuries can disrupt the normal drainage pathways.
Okay, for the time-sensitive low-flow priapism, what's the immediate management protocol?
It's a stepwise approach. The first step is mechanical, aspiration. You take a needle and you aspirate the stagnant, dark, sludgy blood directly out of the corpora cavernosa.
Just to reduce the pressure.
To reduce the pressure and get some of that acidic, deoxygenated blood out of there.
And this is usually combined with a pharmacological step, right? An injection.
Yes. You aspirate and then you inject phenylephrine. This is the key drug.
Why phenylephrine?
It's an alpha agonist. Alpha agonists cause smooth muscle contraction. You inject it directly into the corpora, and it forces the smooth muscle in the erectile tissue to constrict. That constriction opens up the outflow channels and allows the trapped blood to finally drain back into the body. It's a chemical reversal of the low-flow state.
And if that fails, if the penis is still rigidly erect after aspiration and multiple shots of phenylephrine,
Then you have to escalate to surgery. We resort to shunt surgery. This is creating an artificial escape route for the blood.
and Dr. Kamara notes the two common types.
The winter shunt or the Al-Goreb shunt. They're minor surgical procedures that create a connection, a fistula, between the congested corpora cavernosum and another part of the penis like the glans, which has a different drainage system. This allows the dark blood to bypass the blockage and drain away, saving whatever healthy tissue is left.
And for the high flow type, is it the same?
No, completely different. For high flow priapism, since ischemia isn't the immediate worry, the management is often less aggressive. Sometimes you can just observe.
But if it doesn't resolve?
Then the treatment is typically embolization. This is done by an interventional radiologist. They thread a tiny catheter up through the arteries to the one that's feeding the fistula, and they block it off with tiny coils or particles. They essentially turn off the faucet that's fueling the erection.
Okay, that's a lot on emergencies.
Hmm.
Let's pivot now to congenital conditions. Birth defects that need very careful timing and surgical planning in infancy. Let's start with the most common one, hypospadias.
Yes, hypospadias is defined as an abnormal ventral opening of the urethral meatus.
So, on the underside of the penis.
Exactly. Instead of the urinary opening being at the very tip of the glands where it belongs, it's displaced somewhere along the shaft or on the scrotum or sometimes even further back in the perineum.
And a key fact here, this is the most common congenital penile anomaly.
It is, and it's often not just a misplaced opening, it's frequently associated with chordee,
Gordy being.
a band of fibrous restrictive tissue that causes a severe downward bending or curvature of the penis, which becomes really obvious during an erection later in life.
And the severity of the hypospadias dictates how complex the repair is going to be.
Completely. A mild case near the tip is a simple repair. A severe case down in the perineum requires a very expensive multi-stage reconstruction. It affects urinary stream, causing spraying, and it can seriously impact sexual function if that chordee isn't corrected.
This brings us to another one of those cardinal rules, this time in pediatric urology. It's right up there with the Foley rule. Never circumcise a newborn with hypospadias.
This is a rule that every pediatrician, every family doctor, every obstetrician needs to know.
Why is it so absolute?
Because the prepuce, the foreskin, is not waste tissue in this case. It is the vital, necessary raw material for the reconstruction. Surgeons need that vascularized flap of skin to build the new urethral tube, the neurethra.
So if you circumcise the baby, you've thrown away the best possible graft material.
You have, and that guarantees the future repair will be vastly more complex. It'll require taking grafts from other parts of the body, which introduces new risks and complications.
Okay, so we save the tissue. When do we operate? What's the timing?
The surgical repair is carefully timed for between 6 and 18 months of age.
Why that specific window?
It's a balance. Physiologically, the penis has grown enough that the tissues are workable for the surgeon. And psychologically, the child is too young to form a conscious memory of the procedure, which minimizes emotional trauma.
And the techniques for repair are quite varied.
Oh, yes. Dr. Kumaran lists several, which tells you this isn't a one-size-fits-all problem. The Snodgrass technique, or tip repair, is very common for more distal cases, but there are others, like the Mathieu, Mastarde, and Dennis Brown procedures, all designed for different degrees of severity.
Now, let's compare that to its much rarer but much more serious cousin, epispadias.
Epispadias is the exact opposite anomaly. It's a dorsal opening of the urethral meatus.
So on top side.
On the top side. And its significance is that it's rarely an isolated defect. It has an extremely severe association. The complex congenital condition known as bladder exstrophy, this is a major defect where the bladder itself fails to close during fetal development and is actually open and exposed on the outside of the lower abdomen.
Wow.
Epispadias is considered the mildest form on that whole exstrophy spectrum, but if you see it, it immediately mandates a thorough investigation for all the other more severe abdominal and pelvic defects that go with it.
Finally, in this section, let's talk about a congenital condition that can quickly destroy a child's kidneys. Posterior urethral valves, PUV.
PUV is defined as obstructing mucosal folds found specifically in the posterior urethra of male infants. They're basically little flaps of tissue that act like a one-way valve.
So urine can't get out of the bladder properly.
Correct. It creates a high-pressure obstruction right at the bladder outlet, and the functional consequences are severe because the bladder is constantly straining against this blockage.
What are the clinical clues? How is this picked up?
Often, it's detected antenatally. An ultrasound will show hydronephrosis swelling of the kidneys because the pressure is backing up the entire urinary system, even in the womb.
And after birth?
After birth, the infant will have a very weak, dribbling urinary stream. They'll suffer from recurrent urinary tract infections, and over time, they develop long-term bladder dysfunction. The kidneys are under relentless assault.
Explain that feedback loop. How does this tiny valve in the urethra lead to total renal failure?
The obstruction causes massively increased pressure inside the bladder. That high pressure is transmitted backwards up the ureters, often causing vesicreteral reflux or VUR, and into the delicate collecting systems of the kidney.
Causing the hydronephrosis.
Yes. And over time, this unrelenting back pressure physically damages the kidney's filtering units, the nephrons. This leads to progressive chronic kidney disease and, if it's not treated urgently, end-stage renal failure.
There's an interesting protective mechanism here sometimes, right? The body creates a pop-off valve.
That's a crucial concept. In some infants with severe PUV, the body finds a way to vent the extreme pressure. This might be through severe reflux up one ureter, which damages that kidney but spares the other, or sometimes urethral diverticulum forms. These are bad in their own right, but they can ironically act as a pressure relief, protecting overall kidney function to some degree.
Diagnosis relies on seeing this obstruction in action.
The main diagnostic tool is the micturating cystoarithrogram, or MCU. We put dye in the bladder through a catheter and then take X-ray images as the baby tries to pee.
And the classic picture is?
The MCU classically shows a severely dilated and elongated posterior urethra, the part just upstream of the valves, and you can often see the obstructive flaps themselves.
And since this is a ticking clock for the kidneys, management have to be immediate and definitive.
It does. The management is endoscopic valve ablation. A tiny scope is passed up the urethra to the valves, and they're carefully cut or fulgurated open with a laser or electricity.
Instantly relieving the pressure.
Instantly. It restores free urinary flow and hopefully stabilizes the renal function before more permanent scarring and damage occurs.
Okay, let's move from those internal congenital blockages to acquired ones. We're looking at common problems affecting outflow, starting right at the superficial skin level with phimosis and paraphimosis.
Let's start with phimosis. That's defined simply as the inability to retract the foreskin over the glands.
But the key clinical point here is that this isn't always a problem, right?
Not at all. It's considered physiological or completely normal until about 3 to 5 years of age. Natural adhesions keep it tight in infants and toddlers.
So you don't intervene unless it becomes a problem.
Right. Intervention is only needed if it persists beyond that age or if it becomes symptomatic, causing recurrent infections like balanitis, painful urination, or painful erections later on. If it's symptomatic, the definitive treatment is circumcision.
Now for the urgent opposite, paraphimosis. This is the emergency.
This is the emergency. This is when the foreskin was retracted, maybe for cleaning, and now it's trapped behind the ridge of the glands and can't be pulled forward again.
And this becomes a vascular emergency very quickly.
Instantly. The constricted ring of foreskin acts like a tourniquet. It cuts off venous and lymphatic drainage from the glands. So the glands and the trapped foreskin swell up rapidly, which makes the constriction even tighter.
It's a vicious cycle.
It is, and it can quickly lead to ischemia and necrosis tissue, death of the glands if it's not reduced.
So the management has to be a stepwise approach, starting with the least invasive method.
First, you attempt manual reduction. This involves firmly and steadily squeezing the swollen glands for several minutes to push the edema out and reduce its size, hopefully enough to allow you to gently pull the foreskin back over it.
What if that fails?
If manual pressure alone isn't enough, you can escalate to mechanical decompression. This might involve multiple needle punctures into the very swollen edematous ring of foreskin.
To let the fluid out.
Exactly. This lets the fluid weep out, it reduces the volume of that constricting ring, and that might make manual reduction possible.
And if those two non-surgical methods fail, what's the mandatory surgical fix?
The rapid surgical relief is the dorsal slit. You make a cut through the tight, restrictive ring of tissue along the top, or dorsal aspect, of the penis. This immediately relieves the tourniquet effect and restores blood flow.
And then what?
Well, that solves the emergency, but the patient will almost always still need a formal circumcision at a later date to prevent it from happening again.
Okay, let's move back inside the urethra now to talk about acquired internal scarring. Urethral strictures.
A stricture is just a pathological narrowing of the urethra caused by scar tissue, or fibrosis. That scar tissue reduces the channel for urine flow.
And the causes are important because they often predict where the stricture will be.
They do. Causes include prior trauma like a straddle injury leading to a bulbar stricture or repeated instrumentation, iatrogenic injury from catheters or scopes.
Also infection.
Prior severe infection like untreated gonorrhea can cause dense scarring. And then there's the chronic inflammatory condition, lichen sclerosus.
Let's pause on that one. Lichen sclerosus. What is it, and why is it so problematic here?
It's a chronic inflammatory skin disorder that often affects the genital area. It causes pale, thickened, itchy patches. And when it affects the meatus, or the distal urethra, the resulting chronic inflammation and scarring cause these really dense, complex strictures.
And they're hard to treat.
They're notoriously difficult to treat and have a high recurrence rate. And importantly, lichen sclerosis also elevates the risk of future malignancy. It's a pre-malignant condition.
So clinically, the patient with a stricture comes in with classic outflow symptoms.
Yes. A drastically poor urinary stream, needing to strain to empty their bladder, a noticeable sprayness or forked stream, and in the worst cases, complete urinary retention.
How do you manage them? Is it always surgery?
The strategy depends on the length and complexity of the stricture. For simple or short strictures, say less than 1 or 2 centimeters, the first-line treatment is often internal urethrotomy.
That's cutting the scar tissue from the inside.
Exactly. You pass a scope and use a tiny knife or laser to make an incision through the scar tissue to open up the channel.
But what's the downside?
The problem is that every time you cut scar tissue, you induce a wound healing response, which often just generates more scar tissue. The success rates drop with every recurrence. It treats the symptom, but it rarely cures the underlying disease long term.
So for a long stricture, or one that keeps coming back, you need a more definitive solution.
Yes. For long or recurrent strictures, the gold standard is open surgery, urethroplasty. This might involve excising the scarred segment and stitching the healthy ends back together, an end-to-end anastomosis.
But what if the gap is too large to bridge after you cut out the scar?
Then you have to use a substitute material. And this brings us to that fascinating detail of reconstructive urology, the buccal mucosal graft.
Okay, explain this. Where does this tissue come from, and why is it so good for this?
The graft is harvested from the inner lining of a person's cheek and lip. Surgeons absolutely love this tissue for urethral reconstruction.
Why? What makes it so special?
It has 3 amazing properties. 1, it's inherently moist, just like a urethra should be. 2, it has an incredibly robust and forgiving blood supply, which means the graft is very likely to survive and take when it's moved. And 3, its thickness and texture are a very close mimic to the natural lining of the urethra. It's the ideal replacement part.
A brilliant example of borrowing from one part of the body to fix another.
It really is.
Our final section now. This one really elevates the importance of everything we've just discussed by connecting chronic inflammation directly to the risk of cancer.
Yes, we're talking about penile cancer. The vast majority of cases are a consistent type, squamous cell carcinoma, or SCC.
And the risk factors here are crucial because so many of them are preventable. Dr. Kumaran lists poor hygiene, phimosis, HPV infection, smoking, and lichen sclerosis.
And the link between them is profound. Poor hygiene and phimosis both lead to the chronic accumulation of smegma and inflammation under the foreskin. This constant irritation creates an environment that's ripe for malignant transformation.
And that's often compounded by HPV.
Exactly. Add in an infection with a high-risk human papillomavirus strain, and the risk skyrockets. This is why addressing phimosis in childhood is a primary preventative strategy against adult malignancy.
Prevention also relies on early recognition. We have to know what the premalignant lesions look like, the warning signs.
There are 3 significant ones. There's Bowen disease, which is carcinoma in situ on the skin of the penile shaft. There's erythroplasia of Queyrat, which is carcinoma in situ that appears as a red velvety patch on the glands.
And the third.
Bowenoid papulosis, which usually presents as multiple smaller pigmented bumps or papules.
So if any suspicious lesion is found, a plaque, a nodule, an ulcer that just won't heal, the next step is non-negotiable.
Biopsy is mandatory. You cannot proceed to treatment without a piece of tissue under the microscope to confirm the cancer's type, its grade, and most importantly, its depth of invasion. That depth dictates everything that follows.
Let's break down that treatment structure. For carcinoma in situ, the earliest stage, where cancer cells are only in the very top layer of skin, the approach can be more conservative.
Yes, the goal is to preserve as much tissue as possible. Options include topical chemotherapy, like using topical 5-FU cream, or using a laser to ablate and destroy just the surface cells. This is possible only because the cancer hasn't broken through the basement membrane yet.
But once it becomes an invasive tumor, once it breaches that membrane and starts growing deeper, the treatment has to escalate.
It escalates to radical surgery, either a partial or total penectomy. The surgeon has to remove the tumor with a clear margin of healthy tissue around it.
And the choice between partial and total depends on the tumor's location.
Exactly. A small tumor at the very tip might only require a partial penectomy, but a larger, more proximal tumor will demand a total penectomy, with the urethra being rerouted to open in the perineum, a perineal urethrostomy.
The final and maybe most critical part of treatment is managing the potential for spread, groin node management.
This is critical. Penile cancer is notorious for metastasizing to the inguinal lymph nodes early on.
So how is that managed?
The management is dictated entirely by the clinical and pathological staging of the primary tumor. If it's a very low-risk superficial tumor, you might just watch the nodes. But for higher grade or deeper tumors, you have to evaluate them, even if they feel normal on exam.
And modern practice is moving toward less invasive ways to do that.
Absolutely. The trend is toward techniques like the dynamic sentinel node biopsy. You inject a tracer near the tumor, which travels to the very first lymph node that drains that area, the sentinel node.
And you just remove that one node.
You remove only that sentinel node for examination. If it's negative for cancer, you can usually avoid a full, complex, and high morbidity inguinal lymphadenectomy, which is removing all the lymph nodes in the groin. If it's positive, then the full dissection is required. It's about finding that balance between surgical complications and oncological safety.
This whole section is just a powerful reminder that basic care and hygiene in childhood can prevent a life-altering surgery decades later.
It's the ultimate holistic connection.
So we have successfully navigated Dr. Kumaran's high-yield material. We've connected that foundational anatomy to complex pathology and management.
We have. We established that hierarchy of the urethral segments, pinpointing the membranous as the narrowest internally and the bulbar as the most commonly injured.
We solidified those critical don't-dos. Never insert a Foley if trauma is suspected.
And never circumcise a hypospadias patient. Those are rules that really govern optimal outcomes.
We distinguish between anterior straddle injuries and posterior pelvic fracture injuries, and we really emphasize the time-sensitive nature of those emergencies, like the eggplant fracture and ischemic priapism.
Yeah, and from congenital obstructions like PUV, which can silently destroy kidneys, to acquired strictures, where the ingenuity of the buccal mucosal graft provides so much hope, we've really covered the full breadth of this subspecialty.
And what stands out to me again and again is that profound link between chronic inflammation, mechanical irritation, and these really severe outcomes down the line.
You see how something as common as phimosis, or an inflammatory response like lichen sclerosus, sits on a direct path to the highest stakes condition, which is squamous cell carcinoma.
And that leads us to our final provocative thought for you, the listener. Considering that this material repeatedly shows how these early, seemingly minor issues are directly linked to the severity of later disease.
If addressing a patient's poor hygiene and their symptomatic phimosis in your general practice can drastically reduce their risk of needing a partial penectomy 40 years from now.
Doesn't this holistic view completely elevate the importance of primary prevention and general screening in urology? If the goal isn't just to treat complex disease when it arises, but to prevent it from ever taking root, how does your approach to every single routine clinical encounter change, knowing the full life cycle of these conditions?
It makes every history and physical exam a potentially life-saving intervention. Thank you for sharing these sources and for diving deep with us today. Keep organizing that knowledge and keep learning.